The PCA does allow the patient to reach their own minimum effective analgesic dose, which is MEC. It's rapid titration. Usually we give morphine every 5 minutes. It depends on the age and other factors of patient comorbidities and the surgical procedure. And it has better analgesia and less side effects and better patient satisfaction. As you can see here, if you see the analgesic drug concentration and the time, in the yellow marks, you can see the use of PCA, and you're keeping that within the window in the middle, the white shadow, which is the shadow of comfort or analgesia. Above that, it's the side effect window. Below that is under dosing. With the green bars, you can see the use of betadine IM. So you give it at 6 o'clock, it shoots up in the system, goes to the analgesic window, beyond it to the side effects, and goes down. Whereas with the PCA, the yellow bar, it actually stays within reach of comfort or patient satisfaction. So the PCA does give actually superior analgesia than intermittent IV or IM injection. But in major meta-analysis, as we can see in this slide, the major part was actually patient satisfaction and superior analgesia, but there was no significant difference in the total use of opioid or the adverse event or the length of stay. So the management of side effects, you have to manage the nausea and vomiting using ondansetron, Plazil or metoclopramide, pruritus as well, which is a side effect. This is what we call the Oxford analgesic league, and I'll show you in this table. As you can see, the top of the table where you can see paracetamol with codeine Tylenol 3s. The number needed to treat, the less the number, the better the drug. So Tylenol 3, 2 tablets of them, is actually better than rifacoxicab, which is Vioxx, which has been withdrawn from the market, better than diclofenac and naproxen. And as you can see, IM injection of betadine and morphine is actually much less potent than oral Tylenol 3. So PCA, as we said, the advantages are it's the gold standard of post-operative therapy. It enables the patient to titrate the analgesia of their own, no analgesic gap, and high patient satisfaction. But the side effects, it's the significant time and resource, the programming problems with the staff, as well as the potential device malfunction. The epidural analgesia, the advantages it provide very effective dynamic pain relief with movement or cuff. It does lower the doses required for opioids, so you have less side effects of opioids. It does reduce the stress response. Now, the disadvantages, it has significant side effects. It's very invasive, extensive staff time, appropriate staff training, which is very crucial, and high catheter failure rate up to 20 to 15%, dural puncture, headache, as well as increased risk of spinal hematoma and abscess. Peripheral nerve blockade is actually very targeted and excellent analgesia to the organ that you want to, or the area that you want to reach, reduces the exposure to opioid and side effects, as we said. But the problem with it is, again, the extensive staff time, the appropriate training, but it's not useful for big cardiothoracic or abdominal surgery. So the management of opioid overdose, if you got someone who's somnolent and loss of consciousness, you have to stimulate the patient, try and look at the vitals, airway, ABC, airway breathing and circulation, and call for help if you have problems. Differential diagnosis, patient can be having seizure, can be having hypoxia, hypercarbia, hypertension, other medication effect, or electrolyte or acid-base imbalance. But the reversal, you have to use opioid. Now, the key with opioids, which is a pure antagonist for the opioid, it reverses the effect for up to 30 to 45 minutes. So if you're using long-acting opioids, you might have a recurrence of the overdose. As well as you have to titrate it. So if you use a 0.4 milligram ampoule, dilute the 1 ml of naloxone in 9 ml of saline and give 1 or 2 cc's at a time, and you can always give more. You don't want a complete reversal of the opioid effect.